I want to contrast that a little bit with, well, I'll wait because we're getting ready to go over biopsies. But I want you to keep that in your mind because we're going to come back to biopsies again, and we'll probably come back and have to look at this and contrast it. All right, we know that we can do oscopies. What is an oscopy? What does the word oscopy mean, the word component? Examine or view. All right? A bronchoscopy allows me to view what? The bronchus, the lungs. Bronchus part of the lungs. An otoscopy allows me to view what? Oto, ear. Fundoscopy. Fundo. We're looking at the fundus of the eye, the back of the eye. A laryngoscopy, the larynx. Gastroscopy. Colonoscopy. Colon. You get my point, don't you? All right, all that allows you to view. All right, you can also do a thoracoscopic procedure, meaning going through the thorax, and arthroscopic, going into the joint. Can they literally take a scope and enter your knee and look at the inside of your knee? Yeah, they do it all the time. And can they do a procedure through an arthroscope? Well, they make a couple of incisions, don't they? One for the scope, one for the one or two for the equipment, the surgical instruments. So you end up with 3 or 4 maybe little incisions that they might they'll put a couple of stitches in, or you can end up with this great big old incision all across your kneecap, and you can't walk for days and that sort of stuff. Which one would you rather have? An arthroscopic procedure, hadn't you? Okay. There are special codes that have been developed to show when you've used that type of technique. So if you've got a laparoscopic procedure, you'll have a code that says it's laparoscopic or oscopic in nature, as opposed to an open one. Because an open procedure generally causes more resources to be used for the patient. And when you've got an open procedure done and you could have had a laparoscopic procedure done, what's that telling you about the medical care that you got, particularly if you saw House last week? Did anybody see House last week? Well, maybe it was Grey's Anatomy. I'm sorry, it was Grey's Anatomy. What happened is the patient came in and with a raging infection, and they threw back the cover only to find out that he had had an open cholecystectomy because the surgeon that had done it was of the old school and hadn't kept up with the times. And, of course, all the young docs were aghast that they had done an open cholecystectomy and kept the patient, in the hospital for days, and then they got a complication when they could have done it laparoscopically. Do you find many open choles now? No. Sometimes, though, you always have to be prepared when they're going to do a laparoscopic procedure that they're going to inform you through your informed consent that they may have to open you up because they could run into problems. When you're going to do a procedure with a laparoscope and the patient is obese, is it always easy to view the inside organs when you've got an obese patient? So they may have to turn around and open that patient up. You always run that risk. You sign a consent for a cholecystectomy, a laparoscopic, and in that consent it's going to authorize them to do any and other procedures as necessary. So if they end up doing an open, you've signed it. It's okay because they're going to have to take it in further. All right. Take a look at the middle way of the last paragraph on page 56. When conversion, all right, conversion means I thought I was going to do a laparoscopic procedure, but something didn't go well, and so now all of a sudden I've got to shift to an open approach, whether it's a laparoscope, or thoracoscopy, or whether it's an arthroscopy. Then you've got to code only the open procedure. You don't code the laparoscopic, because at that point that becomes the approach to a further procedure. And do we normally code the approach to a procedure, or is it inherent? It's inherent. And see, these little rules get tricky, don't they? And these are the kinds of things that you just eventually got to put in your mind, but until then, you keep writing down, you write in the margin of your book, everywhere you look it up, you write it down again, and you reference it back to Faye Brown and the page you found it on, so in the future when you need it, you can go back and get it. There are some special codes, however. Notice the V64.41 is a laparoscopic surgical procedure converted to an open procedure. Then you've got the 4.2 and then the 4.3. So we also have additional codes that tell us that something was converted from one to another. In this day and time, if you are an insurance auditor and you are auditing a cholecystectomy chart, and it's an open cholecystectomy chart, is the very fact that it's an open one going to raise red flags for you? Yeah, it is. And you're going to need to know why they had to do an open one on that patient. So, will the V64 code tell us that we intended to do it by laparoscope, but something happened and we had to convert?
Yes.
Yes, it does. So it kind of helps tell the rest of the story. And remember, that's what the codes do. The codes tell the story of the patient's care. And if the codes don't tell the full story, then you haven't done a good job in coding. All right, we're at a good stopping point for a break.